Couple of housekeeping notes. It looks like that the KCB room will be changing permanently over to one of the bigger rooms that we used for a caregiver meeting the other day. So we'll be able to move into a little bit different room, a little brighter, a little bit easier for everybody to see, and hopefully a little bit better quality of stuff. Tonight, the camera was broke next door, so we had to move over here. Who's been through Airway Lab so far? Good, bad? Everybody liking it? Okay. A little bit different type of training, trying to keep it changed up, keep it new for you. Okay. So tonight we want to talk about, we're going to start talking about that acute treatment of pain. And whether that be trauma pain, chronic pain, all the cases tonight are typically going to be from trauma related, but it doesn't relate it to, that 10-year-old kid that you're picking up with appendicitis that's about to rupture and he's got the abdominal pain. So we have the ability to move with this a little more. So we want to talk about seeing the forest through the trees, because guys, at the end of the day, we want to see a big picture of what's going on. Can everybody see the screen okay? Is the lighting okay in here? All right, we just want to make sure everything's good. Oh, by the way, this does cover, we have to state this for your state CE patient assessment criteria and for the National Registry for the new NCCP. This will be pain management for paramedics and individual CE for the advanced. So we'll take care of those, adding those in to meet your qualifications. All right, so some of the things we want to talk about tonight is we want to talk about the importance of pain management. And we want to get a position statement from what the physicians are saying is important for us. And so we're going to use the National Association of EMS Physicians. And so that's where we're going to start talking about these things, and we're going to start getting their position on what they feel with Dr. Troutman being a board member for that? No, just your member. Just a member. Just a member of that one. I can't keep track of all the boards and non-boards. So here we go. So we're going to review the basic pathways of our pain. We want to learn about the pre-hospitals, pre-hospital options that we have from our experts about pain management. We want to examine the different types of pain techniques. Because guys, we've harped a lot about this documentation and what ICD-10's got to have versus what we want to see on documentation. And so that makes it hard, so we're going to talk a lot more about those techniques and what the scores are and why we need to see the things we need to see. And then we want to get a better understanding of some pediatric side. Because at the end of the day, everybody knows when that patient is a pediatric patient and needs pain management, everybody has to go A in the protocol book, which is good because we want a way to back that up to make sure that our numbers are correct. Plus, it's something that we don't see every day. Because at the end of the day, if Dr. Troutman needed some pain management and I chose to give him 100 of fentanyl, that's not going to hurt him. But if I got a 40-pound kid or a 20-pound kid and I give him 100 of fentanyl, that may cause us some adverse problems. And so naturally, as pre-hospital providers, we get a little bit anxious with those kid calls. We want to make sure that we're dosing them right. We're going to talk more about that. So as we enter case review, everybody says a whole hour on pain management. But we start talking about some of the things, the ER doctors are going to grapple with me about. We want to give you the education of why this needs to happen in the field, why we give you, Dr. Troutman gives us the ability to do this in the field. And we start talking about, our pain assessment, that's a nurse's job. But it's not. Because it's what we're learning from a billing standpoint, it becomes very hard. I've got to have these assessments in place. I've got to have my scales in place. And whatever's hurt, I've got to be able to document exactly what I'm finding there, or it affects us at the end of the day on the billing side. So we've got to make sure that we have these processes in place. So let's talk about our first position paper. This came out over a decade ago, okay, in 2003. So we learned new things about medicine, and then we let it sit a little while. Then after a few years, it becomes law. Okay, so that's kind of how the process runs over the years. And just because we've done something for the same way 40 years ago and we do it the same way today doesn't make it right. But as what we're learning with pain, there's been many position papers about this that says the lack of appropriate, timely, pre-hospital pain management has been an ongoing concern for decades. And so they've taken a full position of this, advocating pre-hospital pain as a priority during patient care for us. So now it's 2016, we've moved all the way through, so we're 13 years down the road, and the position statement still stays the same. Pain management needs to be a priority to pre-hospital providers. It also needs to be a priority in the hospital setting. and you look at JCO, you look at DMV, you look at all the survey groups that come in and survey hospitals, they're the same. They're very picky about, was your patient's pain taken care of? And if you've ever been in the hospital with pain, some of you in the room, your kidney stones, you've broken things, you want your pain management because it's miserable and it's uncomfortable. So now you add the aspect of in the field. Now we're going to put them in a bumpy ambulance, even with our liquid supporting springs and our smooth ride we have. You're still bouncing down the road. I'm still moving them in. I'm moving them out of the truck. I need to address these pain issues. So as we move back to some of the position paper, most EMS systems do not even have protocols that treat pain, and other than suffering from ischemic chest pain. And we start thinking about these protocols because some places are actually pulling this back, which makes no sense of what all the professionals and what the experts in the field are saying to do. But what's happening is there's becoming more and more narcotic abuse. You saw what happened with physicians over the last year and a half, where they've really gotten strict, and you have to have a certain DEA code, and you have to pass all these things to be able to do that. And so we kind of still have free range with that here. And so we want to make sure that we're educated with how we're administering these medications. So let's understand the pathophysiology, the physiology behind the pain mechanism. What causes that? So our soft tissue, whether it be heat, whether it be cold, whether it be... And so I get that initial pain, and it strikes my tissue, and it starts to move in. Then that inflammation kicks in, and to have direct damage to that tissue, and that starts to move through those pathways through different things, like the body starts sending prostaglandin, serotonin there, bradykininins there, and it really it dumps potassium, and we get a buildup of all these different enzymes in the body, and that allows those pathways, as you can see, those pathways become more fluid. So they're able to send the pain up the chute quicker. This makes it easier for the neurons to depolarize, which is going to send the pain up the food chain. So now we're going to take a little squirrel for just a second. We're going to squirrel a couple of times through this because I want to start breaking it off on, so what's affected at what level? We start talking about our NSAIDs first of all. And our NSAIDs are things that are going to cause anti-inflammatory medications. So these are the things that are going to start acting on our prostaglandins. They're going to start acting on these processes. So we have our COX enzyme that comes in. We have COX-1 and COX-2. And as it starts to break down, it converts the acids down into prostaglandin. As that prostaglandin comes into play, as we just talked about, remember, that prostaglandin comes in and allows those cells to open up quicker and allows the pain to go through. And so as it works up, we start adding our ibuprofen, our aspirin, and our Toradol to this. What it does is it inhibits prostaglandin. Well, if I stop it at that point, right at the actual portion of where I'm hurting, that's that anti-inflammatory. That's where that kicks in, and it doesn't allow the prostaglandin to convert at that point, and it doesn't allow those neurotransmitters to be open and to move through. And so that's how we address pain on one level on the anti-inflammatory side. So at the end of the day, less prostaglandin means less signals that are being transmitted of pain. Okay, so we move into our Tylenol side. Tylenol is not considered an NSAID. Remember that this is not done because of it doesn't have the anti-inflammatory properties. It has very weak ones at that. As the body's releasing the peroxides, it starts to degrade the acetaminophen or the Tylenol. And what happens is Tylenol actually works on the CNS side. So it's only affecting the CNS portion and causing pain control and fever control via the CNS portion only. So you're not going to get any of the anti-inflammatory there. The NSAIDs work on both the COX-1 and the COX-2 side, reducing the prostaglandin, but acetaminophen doesn't have that capability. It mainly works on the COX-2 side where the enzymes also participate in the prostaglandin production, so it actually doesn't allow it to convert at that level instead of at the COX-1 and COX-2. So then we're going to go reline back in and we start talking about the neurons as they depolarize. It becomes more and more easy. So we've got our pain, and now our pain's coming into our spinal column. And this is where I start to get that electrical signal and I say, ouch, that hurts, and I pull my hand back. As we talk about that, once we get to the spinal column, the substance P and the glutamate, the neurotransmitters go through. So as we start talking about it, it starts shooting up to the brain, so we're going to squirrel again. So our drug ketamine that we carry is an NMDA receptor antagonist. And so we start talking about these processes and how our ketamine works. The ketamine actually comes in with the NMDA receptor, binds, prevents those channels from opening. So at that point at the spinal column, that's where my ketamine comes into play and says, okay, you're not going to make it here, and it's not going to transmit more pain to the brain. So that's how that's affected with our ketamine. So at the end of the day, the results are pain signals arrive at the spinal column are less likely to continue up to the brain because ketamine has now blocked them. So as we move forward, and now we're moving up into the brain, so now I've got my pain from my shoulder that's come down through the spinal column, and now it's gone up to the brain, and it gets into the thalamus. This is the first region that receives the signals, and the thalamus is basically the center hub. It starts divvying it out. Now, our brain doesn't have a pain center. I don't have one part of my brain that says, okay, I'm going to handle all the pain, and wow, that hurts really bad, and now I've got to do something about it. The brain doesn't have, once again, a dedicated pain center, so this can control our emotions sometimes. Pain, who's been in such bad pain, it controls your emotions? You've been hateful to somebody. Okay, hey, Stacey's shaking her head, you're probably talking about childbirth. I mean, you're saying, you're looking over going, you caused this. And you're going, where did that come from? Whoa. But that's what happens in that process because it's moved to our emotional side as it gets divvied out through the cortex. This may make our painful experience well. Now, I'll be truthful. I don't see how a female can have a baby and then in 6 months go, I'm ready for another one after going through that much pain. Because the guys would have said, I'm out. I'm done. Okay, so that just proves that the women can handle a lot more pain than the men can. So we got another medically proven fact at that point. So then we're going to squirrel again. We start talking about our morphine and fentanyl because this is where it becomes on our brain side. Opiate receptors are targeted by both fentanyl and morphine. Typically with morphine, this is going to be a little bit of a longer effect that we have than the fentanyl. But the nice thing is on the fentanyl side, with it being a lipid soluble, it's going to work a little bit faster getting into our body and controlling that. Also with fentanyl, this is synthetically produced, so it's going to have a decreased chance of having histamine release. We all know with our morphine, we're having a histamine release. We know that. The fentanyl is going to tend to have a less chance of having that histamine release, which could lower the blood pressure. So we move in and we start talking about modulation of our pain. And so this is where we start to put the whole process together. In any part in this process where I can stop the pain, whether it be at the site, at the spinal column, or at the brain level, I've succeeded in how I'm going to control this patient. So the analgesics that we use is targeted at modulation with different phases. And that's why we kind of allow you that ability, Dr. Troutman allows you that ability to make those decisions. Am I at a mild level? So can I handle it with a little bit of anti-inflammatory? Or do I move to something that may need a little bit of opiate pain control? Or do I need the heavy hitter at the ketamine to make almost a dissociative effect? And so this gives me different pathways of how we are able to take care of our pain. So what happens if pain's untreated? Well, our fight or flight kicks in. Normally, when somebody gets hurt or somebody gets shot, what do? You'll see them typically try to run. That's the fight or flight kick in. As part of that, we have an increase in heart rate, increase in blood pressure, and a decrease in our peripheral circulation. So everything starts to squeeze, blood's being squeezed where it needs to be, heart rate's kicking up faster, blood pressure's going up. But the thing is, my body can't keep this up for a long period of time. I lose my sympathetic response. And so at that point, and we picked up all these people and we say, he goes, oh, I had the worst headache of my life and I've still got the worst headache of my life. He's over there playing on the phone. And you've seen that, or you see people that are saying, it's a pain scale of 10, but you're checking their vital signs and they're at 120/80 and 68 on their heart rate. That's because they still could be having the pain, but they've lost their sympathetic response at that time. That would be for like those major trauma patients that, you were thinking, oh my goodness, this guy's got to be hurting horribly bad. And they probably are, but the blood pressure is, way normal. All my vital signs are way normal. Now, we've learned that just now that our heart rate can increase, our blood pressure can increase, and those are part of those processes. But sometimes they can be on the opposite side of that where they lose that sympathetic. Also, some of the things that happen during this sympathetic response is I have an increase in my blood sugar. Stress hormones concentrate. We talk about the lack of GI, which can cause some of that nausea and vomiting that we'll have, and then some urinary retention. So go back to our position paper. The physicians, the National Association of EMS Physicians came out, and they recommend some criteria for EMS. And this is a mandatory pain assessment. Wow, rocket science, huh? If we're saying somebody's hurt, we need to be able to describe it in a report, in a patient care report, of exactly what was going on with this process. We need indications and contraindications to pain management. We need both non-pharmacological and pharmacological interventions. We're going to talk more about those in just a moment. Mandatory patient monitoring and documentation. That's a great spot. Transfer of patient care. So we need to provide great patient information when I'm giving it over. Patient was unable to lay on the cot when we got him to the truck. Gave him pain medicine because we were in the hospital. The doctor was like, "You tell me he was hurting really bad and he's relaxed and out cold." And you're saying, "Well, that's because I took care of it pharmacologically." And then the quality improvement and medical oversight. We'll talk more about that as we get in. So we see this, we have this young man here, and this young man sitting here, and we say, well, is he hurting? Is he in disbelief? Is he in fear? Is he disappointed? Or is he just feeling tired? That's that look of, I could probably say, well, he's probably got a really bad headache behind his right eye. That would be my assessment of him. But some of y'all may look and say, well, no, he's just, he's disappointed about something. Or he's got something else going on. So that's where part of this assessment comes into place. I have to be able to ask them and document a valid pain scale. And without asking those questions or figuring out on the Wong face scales or whatever we're going to use as to determine the pain level, I've got to be able to document that, and I've got to be able to ask those questions. So what are our options that got approved? So we have a numeric rating scale, we have a visual analog scale, and we have a verbal rating scale. We're going to go through all these real quick. So this is the most common for us. So on a pain scale of 1 to 10, 10 being the worst pain, how bad is your pain? And they always say, it's a 10. It's a 12. Okay? And you get them in the truck, their blood pressure is 110 over 50, and they're playing on their phone the whole way to the hospital, and they're like, man, this is really killing me. My pain's hurting really bad. But we see that all the time, and we all giggle in the room, but we've seen that. We've had that patient. And so we've got to be able to use these processes of saying, okay, you're on a pain scale of 10, your blood pressure is 170 over 99, and your heart rate's 152. Okay, I'm probably buying off he's hurting pretty bad. Now, we can be there, or we can lose that parasympathetic response, or the sympathetic response. And so now we've lost that ability to have the hypertension or the high blood pressure. And so those processes may be trending, so they may be kind of hard for us to evaluate. Now, we all know that females are going to be able to tolerate pain better than men. So, when a man gets a cold, we go to bed for 7 days. I mean, is it not a fact? And the women keep going along and do their thing like they always do. And so I'm not saying that doesn't mean guys can't have pain medicine, because when we're hurting, and we need to take care of that. But we've got to kind of weigh that together, of putting it together maybe with their blood pressure, or are they able to sit still, or what's going on with that process. The visual log, and this is something that I wasn't super familiar with, but this is actually a scale, and they're able to adjust it and say, here's where I'm at with my pain. And so this is another option for pain management that could be used. It's on a scale from 0 to 100, with 100 being the worst pain imaginable. And then we have our verbal scales, and this is, where we talk about our kids. Are you feeling no pain? You have mild pain, moderate pain, severe pain, or just totally unbearable? An example is, did the nitro or the fentanyl provide the greater relief? So if I got somebody with chest pain, I'd give them some nitro, and they say, oh, that is so much better. And you give them some fentanyl, and they say it didn't even affect me. So you can kind of start to weigh those processes and use those. Now we're going to break it down from, once again, from the white paper that was presented, the indications and contraindications to this. How do we break this together? So pain needs to be customized to your patient. Just because you have a bowl of ice cream, Brussels sprouts in there may not be good with it. Everybody agree with that?
Agreed.
Yeah, I don't think that'd be very good. I don't even think 9 months pregnant female on craving would go for that one. Somebody may control pain a lot different. Ibuprofen, they work on them, and they say, ibuprofen knocks me out. Well, think of what morphine's going to do to them. And so I've got to kind of weigh that and it's always smart to ask, have you ever had fentanyl before? Yes. Did it work for you? No, it didn't do anything. They end up having to give me Versed, or whatever it may be. And so you have to kind of weigh that, and that becomes a big part of our medication decision processes. So as we break this down, because now we're adding all these different pain medications, but in what situations can I use them and can I not use them? We start thinking about our active bleeds. So we want to make sure we stay away from our acetaminophen, our ibuprofen, any of our NSAIDs there, but morphine and ketamine and fentanyl will be perfectly appropriate for those patients. For an acute burn patient, I definitely don't want to give them any of the NSAIDs. They're already going to have some liver problems secondary to my burn with it trying to filter everything. So I want to move to my opiates, and my ketamine is a great option. But then we start talking about, well, I've got a pregnant or I've got a breastfeeding mom, and she's got the worst headache of her life. What are my options? Well, I know I can give them acetaminophen safely, but I need to stay away from my NSAIDs right there, but then I can go with my opioids. Now, is opiate transmittable into breast milk?
Yes, but it's not enough to be of a big concern.
Okay.
Most of the time, the suggestion would be to pump and dump one time.
Okay. So it's definitely an option for you if that's something you're weighing up and it becomes a lot of pain at that point. We talking about our renal patients. We need to stay away from our NSAIDs, but ibuprofen's okay. Versus our liver disease patient, they need to stay away from the acetaminophen, but they can have the ketorolac or the NSAIDs. And so we got to kind of start weighing that, and this is built into your protocol now, to where you can flip back through and say, okay, which one's this and which one's that, because it gets a little bit confusing when you start adding all these options for you to be able to take care of them. So you do a little scenario and you think about this. So I've got a dehydrated patient, okay, dehydrated telling me what's my kidney function. Probably not that great at that point because they're dehydrated, the kidneys haven't been functioning. And they got a minor traumatic pain. So that tells me if it's minor traumatic, I've got an option of just about anything. I've got Tylenol, I've got my NSAIDs I could give, and then I can move into my opiates if I need to. But who's also hasn't urinated all day? Is NSAIDs appropriate for them? Are they in kidney failure? Because that's an absolute force, no. But the scenario would suggest that their kidneys are not functioning like they normally would. So that's a high suspicion of something I need to say, let's probably not do the NSAIDs on this time, but we can do the acetaminophen. So it gives me a little bit of an option. My second scenario is she says she's not pregnant, but as you look at her, you would probably say otherwise. She's called EMS for a headache, and so why not give her ibuprofen? Well, that's adding the NSAID to the pregnant lady, and we don't want to do that. So we kind of got to weigh those options and start to use, and that's why we have the protocols built the way we do in order for you to be able to make those decisions. So drugs aren't always the answer. I think, I'm a paramedic. That's what I do is I give drugs. And you're correct. But that's not always maybe the best option. We have other options that may come from better outcomes, maybe with analgesics or without. What about the simple things of stabilizing the fracture? I don't know how many times I see there'll be no documentation of any stabilization, and I can just see this ankle the whole way to the hospital going like this. Well, the pain scale didn't come down. Well, no, because that ankle's fractured and it's wiggling. And so we need to start thinking about those things. Of a simple stabilization, 100 of fentanyl may control that pain. Now, not me. If you pick me up, I want 200 just to make sure we get the pain covered good. And 10 of our said too, Brian says. Okay, we can add all that together. Maybe we'll have to call for orders for that one. Verbal assurance. Hey, I've given you medications. We gave you a very strong pain medication. Is it working? It may be that simple thing of that verbal judo of you saying, I gave you your fentanyl, I gave you some analgesic. Are you feeling better now? It should be working by now. Oh yeah, I feel a lot better. That may be an option for you to start helping with that process. We start talking about our cold packs. This is something we rarely ever see documented, but we may have a nasty fracture or dislocation when we could be adding cold packs to that too to start helping with that process. And then we adjust the patient positioning and padding. Maybe it's that the patient's 6'5" and their ankles or their heels sitting on the end of that cot with a broke ankle right on that metal bar and it's kicking. That may be the most uncomfortable thing, and if I scooted them up just a half inch, that foot would drop down on the padding and it would be a lot better ride for them. So it's the simple things like that I can use with my analgesics on board. in order to help curtail some of this pain. So as we move back to our white paper, we want to monitor the patient before and after analgesic administration and document these things. With our billing lady in the room, she's going to contest this is a hugely important process. Not only for the billing, but for the everyday documentation of what the doctors are reading or what the lawyers are reading of what's going on when they have to read these reports. We wanted this to include vital signs, a new pain scale. That's a big part. Did I make any progress with that? Patient still reporting pain scale of 10, but eyes are closed and resting at this time. Versus pain scale still remained at 10 and patient unable to sit on cot. Two different, says basically the same thing on my pain scale. What happened on my patient side? What am I seeing as the provider of what's going on? Capnography, ECG, very important. And then the patient's response to my therapy, once again. Patient now noted to be playing on phone. Still complains of pain scale of 10. Maybe they got some important business. Maybe they're the director of a big EMS service. And so they have lots of things to be taken care of in a day. But they may just be playing, Pokemon? Is that what everybody's playing these days? Okay, so maybe playing Pokemon on their phone while they're going to the hospital and you're going, what's your pain scale again? Oh, it's 10, it's killing, it's even worse than before you gave it. Okay, so we got to kind of weigh those options of what's going on. So let's look at this report real quick. This is a female in her 40s. Now, guys, this is not the actual picture of what was going on. Kim found that, and it looked really cool, so we thought we'd add it in, okay? But the bystanders on scene stated the patient was at work when her head got caught in what they called a dumper. And then the operator was instructed to open the dumper, and he did the opposite thing. And we squished her head. And so right now we're already going, when we walk in on this deal, we've got a lady with a squished head, and I'm worried about now a head injury. But she's alert and oriented, complaining of some severe pain. The patient states that, and so once again, patient states, that tells me what? She's alert, and that's causing problems for me right there. I was wish she was. Because this is a hard situation, a teeter-totter of if I sedate her and I roll in the trauma unit, what are they going to say? Oh, her GCS is horrible. It's the head injury. No, I just gave her 100 mics of fentanyl. Well, so you caused this. No, I just treated her pain. I just took care of her. She's conscious, alert, and answered my questions appropriately. This is where your documentation of that portion would be hugely evaluated by those physicians. She said she felt, she heard and felt cracking. Wow. So you're going, okay, your head got squished. That's not good. The patient states that it hurts on the left side of her chest and when she inhales real big. And so we start thinking about these things. She doesn't have any allergies, no medications. She takes something for antibiotics for her sinusitis, but besides that, she's okay. The patient's calm, alert, and actively bleeding. Does that tell me a lot? Tells me she's calm and alert, okay, and that I've got bleeding control. Now, they've done a really, really nice job of breaking this down. They say on the left side of the head, an open avulsion reached from the top of the temple area down to the bottom of the ear with the skin and the ear pulled toward the back of the head and was fully exposed. So they got a big flap injury, big avulsion injury. They've done a very, very nice job documenting this. And then they note some on the chest. We got some redness showing. But they took it a step further and they drew some pictures. And so this holds up very well for you because, guys, when's this going to go to court? In 2 or 3 years. Are you going to remember this? Probably. You're going to remember it. This is a big one. Got her head squished. But not all of our calls we remember. And so sometimes drawing pictures for us may be the best thing. This tells me exactly where that injury was and what it was and where it's at. So this just gives us another assessment point. Then I bandaged them. We did some spinal precautions. Well, we took care of all that. Got rid of the backboards. And I noticed that 160/96 with a heart rate of 84. So the 160/96 tells me what? She's hurting probably. Either that or she's got chronic high blood pressure. Or she didn't take her blood pressure pill today. Or she's just non-compliant on the blood pressure pill. But I got to weigh this all together and treat it at the time and go, let's start adding this up. Okay, she heard cracking. Her head's messed up. Let's put 2 and 2 together. Now, heart rate's not a big indicator here. Respirations are a little fast for an adult, 26, she's working a little bit. And then you can see they come in with a pain scale of 10. And I would go, yep, that's just fine with me. So what are our drug options now? We've got pretty much a major trauma who's squished real bad. And so we know we're going to be going to a trauma center. Y'all know where I'm going with this. And if I start to add in these things, and I got to start thinking, at what point am I going to sedate her with ketamine? If it's bad enough, guys, that's what it's there for. We'll have to do that. But they elected to go with fentanyl right now, given for pain control due to trauma. Did a nice job documentation. Got an 18 gauge in them. Gave some fluid, some oxygen. Patient was calm and alert. Now patient's calm and alert right here. So I'd probably go with my lesser of my evils. Now, if I can't keep her on the bed, and I'm worried she's alert and oriented, but I can't keep her on the bed because she's hurting so bad, that may be one of those I may have to cross over to that ketamine side. But if she's not alert and oriented, then I got to start worrying about is that the head injury side. And so, which way am I going to go here? So you got to kind of weigh that and put all that scenario together. She still remains calm. She's oriented. She's after receiving her pain medication. She's doing pretty good. Once again, female's going to handle the pain a lot worse. I've been crying like a baby. Give me more, give me more, give me more. So we get another set of vital signs. This is 3 minutes from the ED. We've had 100 mics of fentanyl. And we noticed that our blood pressure is 178 over 108. So is that our head injury? Is that our heart trying to perfuse? Is that my body trying to perfuse a sick head? Because mean arterial pressure now is probably 128 to 130s, mid 130s at that point. So we know in order to perfuse a bad head, we need between 90 and 110 on our mean arterial pressure. And so we're kind of weighing that. We're going, okay, is this the head trying to perfuse because my heart rate's still kind of low, or she's still hurting? Well, we know she's still alert, she's still oriented. So that weighs it to where I could address that issue more. Now, not knocking on the ER at all, but when's her next pain medicine going to come?
A little while.
A little while. So this may be time, and it's not their fault because the doctor's got to come and do an assessment. He's got to come in and figure out, okay, is this your head that's squished? Do I have a bleed in there? Do I have this? Do I have that? And then my nurses need to assess, and then I need to check the respiratory. Do we need to intubate them? Where are we at in this process? So I've got to kind of weigh that. I would have been prompt here to probably might have given her another 100 fentanyl, not knowing the time frame of where that first one was versus this one. And so we know we can give multiple doses of that up to 300. So we looked at the head CT, and she had a abnormal, well, I don't know any fractures in the brain that's on the skull that's normal, but they call it an abnormal 4 millimeter depressed temporal fracture, also with a subdural hemorrhage, and she also had an acute left side C7 transverse fracture. So she's got some injury.
Well, guess what? She was not on a backboard and there was no negative outcome, was there?
No, there wasn't. So that's why we don't have backboards anymore. Even better point. So we know she had trauma. Guys, we knew going into it she had trauma. And we made great decisions here on not sedating her further. Now, if we needed to, we could have. With this major trauma, if we needed to use a bigger drug, we have that ability. But the crew did a great job putting 2 and 2 together, trying to take the lessers of the evil, because she was alert and oriented, answering questions. And so let's try to keep her as alert and oriented as possible.
I'll go ahead and say, I know I told you I'd go at the end. I was just going to make a couple comments about this case. I know we really talked a lot about looking at vital signs, using those to indicate or be a clue on giving pain medications. To me, when it's a trauma patient, I worry less about that because obviously this patient, I could be from here, they could be across the room, and they hurt, right? I mean, everybody's had a little cut that hurts, so you can imagine what this feels like. Or if there's an obvious open fracture, or even a closed fracture, obvious deformity, I don't care so much about the vital signs. I'm more worried about the hypotensive person and then needing to watch what are my narcotics going to do. And we kind of cover, narcotics. Whenever we have a significant trauma, we want to use narcotics, but we want to be very judicious about that because on that receiving side, especially when we're worried about a head injury patient, now we got to wonder, why is the patient altered? Is it because they have a bleed, or is it because they just got 300 micrograms of fentanyl? So just that's the thing you got to balance. And, especially, we're using more and more ketamine, and, obviously ketamine, what does it do? It's a sedative, dissociative. So if you give ketamine, they're gonna act a little slowed, right? That's part of what the medication does. So just remember that whenever you give those medications, always try to think of what's gonna happen in that trauma bay whenever everybody's in there. Put yourself in their shoes sometimes. We haven't had a problem with it, and we've, let trauma know and our ER docs know that we want to treat the pain, but we don't intend on bringing a bunch of patients snowed with narcotics, because we could do that. If we gave a ton of narcotics, they'd be snowed and everybody would get intubated and we'd have problems. But I don't think we do that. I think we do actually a pretty darn good job. That's always what we get from trauma too, that they think we have appropriately given big doses of narcotics when we need to and not when we don't need to.
A prime example of that was this. So it made a great choice there of trying to keep that patient alert and oriented and not alter that with a heavier drug. So let's start talking about pediatrics, because this is where it becomes a little hairy for some of us sometimes. 9.2 million children every year that are initially treated in emergency room because of an unintentional injury. I want to add that unintentional in there. Okay, this ranges include from newborns to 19 years old. Just by the number alone, that the number is understanding that pediatric trauma, we need to treat these people appropriately. There's a bunch of them, okay? I don't know a lot of 40 and 45 and 50 years old that are riding around on a skateboard, but I know a lot of 10, 11, 12, 13, 14, 15-year-olds that are on a skateboard. Okay, the old guys that are on the skateboard, they're the ones that, they're hip fractures, so we gotta be careful. Us older guys getting on. So, we want to talk about how these kids are built. First of all, they have less fat. We know they have more elasticity in their connective tissues. We know that they have more pliable skeletons. And we know that they have a tightly packed thoracic and abdominal cavity. So what that does for us is that distributes that traumatic force more widely through the body. And so nearly 50% of the children with serious traumas have a potential for very severe pain. So we want to make sure that we're getting those issues addressed when that arises. So the studies have shown that that several medical centers found all ages that pain may be untreated in the emergency department. This is on the ER side. And so once again, we started talking about, we know we've got to take care of these issues, especially with our pediatric population. To sit there and watch your child hurt is not right. You're going to have a not happy mom and dad. That's going to make the situation even worse. And I've got a child that's now going to be uncontrollable, unconsolable. And so that becomes very hard with how we're going to deal with that. Physicians may still fear that that administering opioids will mask or make it to where I can't see any further injuries. I don't know anybody that's going to take somebody to surgery without doing a fast exam on a gut, on a major trauma, or a CT scan to know what's going on. They don't go in there and just start cutting. You think?
There's a penetrating injury
Well, the belly. I'm talking just blunt.
Oh, sorry.
So they're going to scan it real quick and they're going to see what it is. So you giving them fentanyl is not going to mask that, and they're going to go, oh, we got to take a surgery without doing anything. They're going to take a look at what's going on. This is penetrating.
Yeah.
The authors actually found that a decrease in management errors where adequate pain control provided these children. They weren't getting what they needed, is what the final white paper said on this. In fact, it was so bad that medication administration was reported as low as 0.3 to 37%. Astronomically low numbers in order to that they were not treating these pains. Historically, children are less likely than adults to receive opioids for moderate major pain. And so we're just not taking care of those kids like we should. So this little kid right here, we're going to rate his pain. Well, that could just be a gas bubble. I mean, you look at him and you're going, wow, that could be a lot of different looks. That could be, I got bad milk on my tummy. That could be, I'm hungry. That could be a lot of different things. So our kids and even our adults may be different assessment, because some of our adult population with special needs may be very hard to act like children. And so it may be very hard to assess them. They're still going to hurt like you and I do. They still have the same nerve endings you do. It's no different than our LVAD patients. Just because they have a special device, it doesn't mean I can't treat their pain, because I can. And so I've just got to be able to get a scale for what that kid's going to understand. Once again, our older children, I can say, on a pain scale of 1 to 10, 10 being the worst pain, how bad's your pain? They're going to be able to answer me. 9 or 10, 11, 12 years old, they know what pain is. They're telling you about it. Then we have the Wong-Baker face scale. We're going to talk about these. And then the flat scale, talking about our infants. We start, since we all know the pain scale of 1 to 10, the verbal, that's pretty much covered. But then we can use this process. This is in your protocol book. And so I can sit there and I can show a kid, where are you at? What do you hurt? Get on their level. Meet them where they are. Because the 3-year-old is going to be able to point to that and say, here's where I am right here. And it just may be a point. But I can address those issues at that point. Then we start to move about our flat scales. We have our face, legs, activity, cry, and consolability. This is on a 10 scale. Once again, a little bit more cumbersome for us. When was the last time anybody ever gave an infant here narcotics? Anybody tell me? Has anybody done it in the room? In the last 2 years? No takers? You did?
I wasn't on the truck, it was in the ER, but.
Oh, well, okay, but still kind of, it's unusual. You can see one person in the room. It's something we don't treat because it's very hard to us to determine, is this kid hurting? How many times does a kid scream bloody murder all the way to the hospital? A baby in the back of your truck? Probably a lot. Now, is it because they're scared because you're looking at them? Or because they're in an unfamiliar place? Or because mom can't hold them because that's not safe to do so on the cot? To strap them down properly? Because they're hurting? Or is it because I'm hurting and I got them strapped down in a car seat and mom's sitting beside them and I'm trying to console them? They don't know me from Adam. They don't like me. So that makes it very hard for us to determine at what point do I start treating pain for an infant. We use the facial expressions. We start talking about, is there is there any expression, no particular, or is it smiling? Do they have grimace? Are they withdraw? Are they just not interested? Or are they frowning? Do they have the quivering chin or clenched jaw? Their legs, are they in normal position? Are they flexed? Are they tensed? Are they kicking and screaming the whole way? The activity, are they lying there quietly, being consoled by mom? Or are they squirming around, shifting back and forth, they're tense? Or are they rigid and jerky? If they're jerking, we're probably thinking seizures, so that's kind of a hard one, but you've got to kind of weigh that. On the cry, are they asleep? Are they doing well? Are they whimpering? Or are they a bad cry that I can't quite get them to calm down? And then consolable, are they relaxed? Are they be able to be talked to and be consoled? Or are they just unconsolable? So that's just a different way for us to be able to size up these kids that can't talk to us. That's a hard thing. Some of you moms and dads in the room with brand new babies, you kind of look at those babies sometimes and you go, you get a colicky kid and you see, they're over there kicking and screaming the whole night and fussy and you can't get them calmed down. You're going to see that pain because they're hurting. Now, is that a reason to give them narcotic? It's not what I'm saying.
Benadryl.
Benadryl. Dr. Troutman says Benadryl at that point. Neonates feel pain too. The same number of nerve endings per square inch in the body on a neonate as it does on us adults. And so they have the ability to have pain there. While there are some understandable hesitations with kids and newborns and giving them pain medications, sure. As soon as we delivered a kid and, we noticed that, the kid's got a dislocated shoulder, which can be common, I'd be scared to death to give that kid narcotics. The doctor was going, it's not that big of a deal. Not my
Obvious trauma and burns.
Right.
Those two.
Not my comfort zone though, is it? And so how do I assess that pain? I've got to be very aggressive and I got to start thinking about that baby. That baby's hurting. And so I need to address those issues anytime that I can. Need a reference? Well, here it is. This is in the back of your procedure 19. We have all of your pain scales listed there, able to go through them. Make yourself familiar with them. I'm not very familiar with this one right here. I have to sit there and kind of look at it, kind of get it out and go, okay, kid, which one are you? That's nothing wrong with that. That's why we have protocols in place. So let's look at some reports. Twisted ankle, tangled affair. So a 6-year-old female was on the back of her mom's bike. I guess they call that, back when I was a kid, we call it pumping them. And you used to, some of y'all too young to understand that, but we used to give people pumps, they'd get on and they'd put their feet on and then they end up getting tangled up and then we'd all crash and we'd have broke bones. So we ended up, they took a little spill. Child was on the back with his legs up on the frame of the bike for support. Fell between the wheel and the frame, causing the bike to roll over. So they had a one bike rollover. Giggle a little bit, but that's okay. That's a bad joke, I guess. Won't use that one again next time. Having an abrasion with swelling to the ankle. Patient fell from the bike with his mother. No loss of consciousness occurred, and the patient was in some pain. Conscious alert, breathing normally, mental status does a great job documenting here exactly what they found. Trauma noted to the lower right extremity, and then they come in and they document it. Here's exactly what they found on this spot. I can't stress the importance of, if you are telling me that a lower right extremity is hurting, I need to know what you found there. Billing has to know what you found there. The physician, when they read your report, has to know what you found there. I don't know how many times I see a report that says stuff like this, a great job, and then right here, assessed with no. We'll see it all the time. We get in habits of pushing buttons. I've got to have that documentation there of why it is what I'm calling it, exactly what I found. Did a great job talking about the abrasion to the ankle noted, swelling to the site was noted, no obvious deformity. He was having pain to the ankle. Main source of pain for the patient was right here. That's a powerful statement. Main source of pain. Patient's telling me this is it. That's all that's hurting is right there. Excuse me. Then they talk about the knee a little bit. He does have some pain in the knee. No deformity noted, swelling. Does a very, very nice job documenting. Can't stress that enough. We have to have that in that report so we know what's going on with that patient. So they get to their portion of it. Arrived to find the patient sitting on the ground. Sustained an injury while riding a bicycle. Injury was isolated to that right leg. That tells a trauma doc a lot. That's not saying they're not going to rule out an abdomen, a pelvis, a head, a neck, a back. But it sure tells us that this is the only spot this kid was complaining of. The right knee through the deformity kind of goes back through it. Ankle swelling with significant abrasion noted. And so it does a very nice job. Denies any head, neck, back pain, spinal tenderness, denies any chest discomfort, denies any respiratory, abdominal pain, Does a great job documenting all these things. Talks about the fall. Then we do some spinal precautions. We look at a blood pressure. Okay, 6-year-old, 138/62. Is that hypertensive for them? I would probably say a little bit, but I'd have to get the actual book out and kind of look at what's normal for a 6-year-old kid. I don't keep that off the top of my head all the time. That's hypertensive for a kid. Okay, heart rate's 128. Is that tachycardic for a 6-year-old kid? I'd say so. Is this kid hurting? You bet. Once again, documented pain scale of 7. So so after everything I'm reading, I'm looking at the vital signs, I'm kind of adding it together. Okay, we're looking good here. Cardiac monitor, do another blood pressure. Now we're even up higher, 139/96. Still got a heart rate now, 142. Ooh, we shot up like 17 points in like no time. So I've got to start weighing that of what's going on. I get an IV, I give some fentanyl. Now, protocol gives you 2 micrograms per key. This child was 25 keys. So 2 micrograms per key, that's 50. They elected to give 25 here. Is there anything wrong with that? No. You know, it might have been just a small bill kid. You're like, okay, let's see how 25 does. I mean, the kid's the kid's hurting, yes. But has the kid got a leg amputated? No. So I kind of can weigh that of what's going on. So they chose to do 25 mics here. Maybe tried half a dose just for monitoring, see what the effect was going to be. Can I always give another 25 to make the 50? You bet. Can I take away 25 when I give too much? No, but I can switch over to Narcan. So you've got those options if you have to. Just thought I'd add that point. Great pain control here. 117/70. Heart rate went to 112. Very comfortable. Moved along. Respiratory is 24. Everything came down and did nice. They got the kid hooked up and he was comfortable. Breathing, nice documentation. Mental status remains normal. Patient appears to be more relaxed. They did a great job here. Pain scale, once again, wow, we saw improvement. Did we fix the pain? No. Are we always going to fix all the pain? No. But am I just going to make somebody comfortable where they can sit and not enjoy the ride to the hospital? Because the only anybody really enjoys the ride. Well, there's probably a few, but we send those to community medicine folks. Let them do it. The ones that like to go to the hospital for that. So we have that option, and so we took care of his pain some. The narrative, once again, they broke it down very nicely. Isolated trauma to the right leg, turned over care. So how was the patient moved? Now that was one thing that we like to see. How did you get into the cot? Patient was a full body lift. For billing purpose, what does that do for you?
That says a lot.
All the difference in the world. Okay, it may be I just help Alan. I hold him by his elbows and two of us get him to the cot and get him sat down. Does that help you? Versus homeboy got up, hopped on the cot, and he strapped himself in. So you got to weigh that of where I'm at. So how did the patient get to the cot? Because we did a great job documenting that patient staying isolated. Okay, patient was given pain medication for comfort, transported in full report. So how do we get him to the bed over at the hospital? Patient full body lift and move him back across. And so we have that option, so we need to try to use that and try to make paint the best picture possible of how we lifted, how we got them, and how we moved. Anything here you want to go on? Okay. Traumatic injury of a 9-year-old. So we break this down. EMS was advised that the patient's friend was in a shower curtain and fallen on the floor and walked in and put a metal hook from the shower curtain into the foot. And everybody's in there going, that's just bad right there. Mom states, everything was cool, everything was fine. Patient was alert. We get there. Patient was crying and grimacing in pain, and there was about 1 millimeter, that should be of blood, coming through where the hook was still penetrating the patient's foot. They've done a very nice job breaking this down, explaining that this hook was still in the foot. Did a very nice job there. So this gets a little wordy, so I'm going to kind of paraphrase a little bit. But the patient was found sitting on the bed, was complaining of pain of 10 on 10. And, I'm probably thinking bottom of the foot, that's going to hurt real bad too. The patient's mother was unsure about how much the patient weighed. Can I guess that? You bet. Okay. And if I don't, on a 9-year-old, what are my other options? A Brazil tape. Good. We can get that out. Patient with really not being sure of that, we just gave 25 micrograms, and we're thinking, you only get 25 to a 9-year-old. I mean, that kid was hurt. You got a hook in the foot, and you're waiting all these things. But you start reading further, and the patient states they feel a lot better. The patient states that vital signs started to come down. And so as we start to talk about this, the Brazil tape's built in right there for you, quickly available for you to get in. Cardiac monitor, heart rate 143 over 98 with a heart rate of 122. Is that hypertensive for a 9-year-old kid? You bet. You bet it is. And so we need to probably, hey, this kid's hurting pretty bad. Let's take care of it. So we do an IV. We do some fentanyl. Once again, we get them comfortable. The patient no longer appears to be in severe pain. Very nice job documenting on what that effect was of that patient. Now, blood pressure 126 over 89. Is that still hypertensive for that kid? Mildly, especially on your lower side. Maybe you got to kind of weigh that. And then once again, we got to the hospital now. Here's a great spot where it says the patient was moved to the hospital bed using a full body lift with a sheet. That tells me how I got them there. I can't stress that enough to you. How you get them to the cot and how you get them to the bed at the hospital. Patient, back doors were open of ambulance, patient stepped out and walked in. All the way to triage. So there's a picture of it. Oh, it looked like it's almost in between those metatarsals there and getting on the implant. Yeah, I'm done, I'm out. That hurt. So anyway, they got 4 more of morphine and some Ativan at the hospital and they pulled it out. Y'all just grab it and just yank that out.
Yeah, but
You better give me some ketamine.
usually get an x-ray first to see if it is in the bone. So you brought up a good point. Remember, pain medications are titratable, and if you look at whenever a patient gets admitted, their orders might say 1 to 4 milligrams of morphine, Q 2 to 4 hours, so it's titratable. It's kind of, nurse gives a little, if they need a little bit more, give a little bit more. So keep that in mind. Just a couple other things. We talked a lot about trauma, kind of narcotics. Don't underestimate NSAIDs and the other types of pain we encounter. The back pain, the headaches, even maybe some abdominal pain, kind of the non-traumatic stuff. Remember NSAIDs, Tylenol, Motrin. Tylenol is not an NSAID, but also Tylenol for pain. And the Toradol, that's fairly new. We used it maybe a year or so now. Those are really good pain medicines, especially for that back pain, headache type things. And there's not a whole lot of side effects, but just remember the Toradol, the NSAIDs, we want to be real careful on the renal patients. right? And I think it's over 65 is where we do a half dose, so we're saying currently. And if there's a concern of a known renal disease, or I think we gave the presentation, if somebody looks dehydrated, maybe their kidneys are shocked a little bit, it's probably not the best option to give the NSAID, but if it happens, it's not like it's malpractice or it's the end of the world. It probably isn't gonna cause a problem, but there's just a concern that it possibly could. Same thing with pregnancy. If you happen to give a pregnant patient a ibuprofen or give them Toradol, the chance of a risk that fetus is extremely, extremely low. We just don't routinely want that person taking a lot of NSAIDs. So, you know, because I know occasionally we've had episodes where it's happened, don't get the feeling of, oh my gosh, I've messed up this fetus. That's probably not the case. You know, I think the last thing I want to mention is, I talked a little bit about making the patient comfortable. And that's really huge, especially on these extremity concerns. You know, stabilize them. You know, not only for the concern, we have good pulses and such, but I like Chad did a lot better with the ankle floating around, but that hurts, right? So if you can stabilize that, that's going to go a long ways. And, you know, ultimately, when we get those patients in a splint, that helps their pain significantly because it quits moving. All right, that's all I've got. You got a question?
No, I was gonna see if you would touch on, we've talked about it, which as I do my drug slip review, I kind of see this more and more and more. People with migraines. We have a lot of people that treat the migraines with the fentanyl,
Okay,
but they're coming back
so
repeated.
they're coming back and repeating the dose?
Well, no, they're calling more and more
Okay.
because that rebound.
Right, so here's the thing, and we've talked about this protocol-wise, if we should say no narcotics and headache. So if you look at the literature and look at science, narcotics and headaches tend to cause a rebound headache. For some folks, you know, they'll say the only thing that helps is a narcotic. But the better option is something like Toradol. We don't carry like Compazine, have you heard of Compazine? It's kind of an anti-nausea type medication, Reglan as well. Those actually both work really, really good for headaches, and that's some of our drug of choices in the ER. Narcotic really shouldn't be the first line. You know, I, for the most part, if this is the chronic migraine type person, I would more try to go with an NSAID, Tylenol, something of that sort. Now, if this is a head injury, something of that you're thinking, then, you know, then certainly go to the fentanyl. But the chronic migraine, narcotic's not the best thing because it often will wipe the headache out, but then it's well described as getting a bad rebound headache back in the next 24 hours. And occasionally you'll get somebody, they'll tell you, I don't want any narcotics because they've been there. You know, they felt really good for a little while, then that next headache was twice as bad. That answers the question.
Absolutely.
If NSAIDs are going to use an anti-inflammatory method to treat site pain, how does that work on a headache when that's in the brain?
As far as the mechanism of action, I couldn't tell you.
Okay.
I can tell you those some Toradol, Benadryl, and Compazine, that fixes 90% of the headaches that come in. But I don't know. Yeah.
I had a patient that, she fell and had real bad like hip pain, and I treated it with fentanyl and everything, but the family there was really, really concerned because she had Addison's disease and everything, and she was like, before you do anything, you want to make sure that all this is compatible with it. And when I got to the ER, I kind of asked the doctor about it. I don't know if he's a doctor or if he's a PA, but he said I wasn't going to give her Toradol anyway, like I was not, but they were saying typically you want to steer away from anything that's absorbed or through the kidneys or filtered through the kidneys. Is that, I mean, what was your take on that?
Yeah, you know, so Addison's is probably largely overdiagnosed in some places. And a lot of times traumatic patients or patients who get sick, you know, they end up needing high dose steroids and such. So just with that history, high dose steroids, can those be hard on your kidneys? They can, right? Just like NSAIDs, you know, it's a non-steroidal, but they both can be hard on your kidneys. So yeah, I think somebody that we think or alleged has Addison's, I'd probably steer away from the NSAIDs. I think fentanyl is a great choice.
Any other questions?